Are there other terms that I am not hearing about? Because, sir, I have seen the construction going on in the St. Andrew area, the Scotland District area, with loans that we have, I believe, taken from similar Chinese development banks. And it seems that those loans came along with the terms that we must use Chinese construction companies. And the method of construction, the people, the workers, the equipment, everything, very little of it is resounding to us here in Barbados. We have extremely good road construction companies in Barbados that have served us well for decades. We do not need Chinese workers to come to Barbados to show us how to build roads. And in fact, what I have seen of the building, especially on the East Coast Road, those of you who might have the misfortune in the last 6 months to a year to have to travel down there, it's not moving with any speed. It's not moving with any organization that is any better than I have seen from the Rayside Constructions or the Infras Constructions or the C.O. Williams Constructions or the many other construction companies who build roads in Barbados. So, sir, through you, as I say, I have no objection to this loan, the loan itself. It is for a good purpose, for our healthcare system. It will have durable value if it is spent wisely. But I am asking, is there some other condition that is not being told here, or is this going to public tender where Barbadian companies who are in the construction of buildings like this can build it with this money? Or is this already been agreed that it must be built by a Chinese firm? Mr. President, I'm obliged to you, sir. Thank you.
Thank you very much, Senator Mallory. Senator Dr. Connell.
Mr. President, thank you very much for having the floor, and also thank you, members, for your very kind words of welcome to this place and not the other place. It certainly was not my intention on the first sitting in Senate to give a maiden speech, but certainly I could not miss this opportunity because what I'm about to share with you and the public of Barbados really is something that is very close to my heart. Allow me just to paint a picture. For my entire life in my field, I've worked in public service. I started at the Queen Elizabeth Hospital as a medical student in '97. According to some of my students watching, there probably were no textbooks back then either. And I worked my way through the hospital as an intern, as a senior house officer, as a registrar in the Department of Medicine, not ENT, and finally as a consultant. I then furthered my training in a clinical specialty in internal medicine, clinical pharmacology, which is a research specialty, and it naturally fit then that I became more positioned with the University of the West Indies. And so although I work at the hospital, I'm going to be very careful because I know that members of the university community may be watching. I work for the university. Against this backdrop, I want to speak to you briefly, however, on what I hope will call this chamber to recognize a sense of urgency. Now, doctors are notorious for making everything urgent, but I hope that the picture that I am painting is that of an urgency, and dare I say, an emergency. The burden that the hospital faces has changed significantly. Let me just give you an example. When I was an intern, with an afro, a lot more hair than I have now, I saw one stroke. More hair, which isn't a lot. One stroke, possibly every 2 weeks. One stroke, and it was really someone who was maybe in their 70s and 80s, which I no longer call elderly. But certainly when we saw a stroke, everyone rushed to the room because you don't know when's the next chance you're going to see a stroke. A medical student, 2 weeks ago, I said, if you've seen any interesting cases, we were on call, and she said to me, just the usual stroke. Just the usual stroke. And I'll tell you why it's a usual stroke, because looking at the ward census for the university team then, that's a month ago, we were admitting on average 2 to 3 strokes per night. So that's a huge change. What struck me is that this young lady who was very nervous presenting for her first time to a consultant on ward rounds, and I know at least one member knows how intimidating that can be, she said to me that, oh, but this is an old stroke, as in a stroke occurring in an older person. So of course I'm expecting 80s, 90s. This is a 45-year-old man. I say this to make the point that even the generation of practitioners that we have now have become so accustomed to seeing a significant NCD burden in younger patients. So the demographics have changed. This is no longer the old person coming in, and I had to explain to some non-Bajans recently, having a Passover. This is a young person in their productive years, contributing NIS, hopefully, and making a contribution to their country. In fact, I will go further by saying that this young stroke I am referring to is married. He has a daughter, 3 years old, and his wife, who was sitting next to him in the emergency room in shock, was pregnant. This is serious. And sometimes when we as academics, and I am guilty of this, we look at data and we mention X number of people will die of stroke, or sometimes it's hard to face the reality of what is in front of you, the person and the family and the disability, and how this will change someone's life in front of you. There are several reasons why this has occurred. It hasn't happened overnight. It will not change overnight. But what I'm about to say should bring cause for you to believe that we are not in a good place. We have this aging population. The aging population, many would argue, is a good thing in terms of medical science. It means people are living longer. When I was an intern and Chris Maynard was, well, he was probably still a consultant then. But when I entered, when I entered the emergency room, someone like a George Nicholson, who is now deceased, would say to me, if you come in with a heart attack, we give you morphine and a Bible, right? Because that's all that we can do for you. Relieve your pain, hope for the best, and pray about it. Now someone comes to the emergency room. Time is everything. Time is everything. Time is in minutes and hours, not days. They have to get an ECG. They have to get these labs done. Then they're going to get all these expensive drugs. In fact, I am aware from reading the newspaper and from following the debates in this same chamber, I wasn't anticipating anything, that this government has expanded the services of pre-hospital care in some areas, like for heart attacks and for stroke. This is significant. It not only means that the patient coming with an identical diagnosis maybe 20 years ago now gets a lot more done, and the cost of those drugs, you know, a vial of a clot-busting drug can be hundreds of thousands of dollars, right? An interventional cardiologist, this isn't just a heart doctor, this is someone who can take you to a cath lab and within hours unblock the arteries in your heart, significantly improving your mortality. That training takes years. My colleague who be trained in internal medicine, who traveled and trained at Johns Hopkins, which is one of the top centers, and the Mayo Clinic, I know. The reason she is back here is certainly not the salary, but because as a true St. Lucie person, she wanted to give back to her country. This is the cost of health care. It's expensive. Now, what about the human cost? Because remember, I started by saying that that consultant would have said, give them a Bible and some morphine and leave them with the family. And if they're alive the next morning, then okay, well, you've made it past the worst. We'll then try to treat your heart failure and hopefully get you out of hospital or not. This person who is in hospital is utilizing staff. The nurse that has to stand by the bedside to watch a drug being administered, because you can't have this person in a corridor, like you may see several patients in A&E corridor. They have to be on intensive care. Intensive care takes money. You have to have a specialist, doctors and teams seeing them. They may have to go to the cath lab to get a procedure done. And after that, continued monitoring. It is extremely resource intense. When I was a registrar in the Department of Medicine, I covered both the emergency room, ward calls from difficult people like surgeons, as well as the intensive care unit, the medical ICU. One registrar was the only junior doctor on covering all these areas. Now, the ICU care is such that there is a dedicated registrar just on for ICU because of what is being done for these patients and the fact that they are so ill. So it's aging, yes. We are doing a lot more for patients. We are investigating them. Some might say we are investigating them too much at times. But then there are also issues inherent to any institution. And let me say I have trained at what I consider to be one of the top hospitals in the United Kingdom. The same issues that occur at the QEH, I have seen at St. Thomas's Hall with all the resources. They're just inherent hospital challenges. Many of them relate to communication, so some of them aren't even expensive things. Poor handovers and poor communication. Relatives are upset. Who is my father's doctor? I can't find, I don't know who consultant to speak to. The amount of times when I am on service, meaning that I'm covering the hospital, and I have to get a call from a politician because a relative has been trying to get a doctor unsuccessfully for days. This is in 2025 where we have all this technology going on. You can do all these things, but you can't get information urgently on a patient or a relative as next of kin. And Mr. President, we mentioned the difficulty and nuances of next of kin over lunch. These are not difficult things to fix either. For instance, there could be automated systems where relatives call in and they are able to state their relative's name, who they are. It is authenticated that they are the next of kin and verified. And an appointment system is set up so that doctors can prepare to chat with relatives with the information that they need. This reduces anxiety considerably. 9 times out of 10, when I have a meeting with a patient's relative, and by this time they're usually fuming, it's because they've been trying to get hold of anyone desperately for days. I have to always start by saying I am embarrassed and I'm sorry for this wait. I didn't get your messages, or I did not, or sometimes we're trying to contact them and we can't get them either. This can't be satisfactory in 2025. Now, I promise not to talk about a pandemic, and I will just call it the pandemic. But certainly there has been a COVID effect, whether we admit it or not. The COVID-19 pandemic has also caused an uptick in the NCDs. Whether you believe what COVID has done to all of us, we do know for sure, and there's WHO data to suggest this, access to care, possibly delayed access to care during the pandemic, meant that people were diagnosed later with their cancers, rationed their drugs. I had one lady during COVID who said to me, well, look, you on television talking about if you have high blood pressure, don't come near the hospital. And then you're saying that I must come to the hospital to get a prescription refilled? Forget that. I take in one tablet one day, another tablet another day, and I'm spacing my tablets out so that I don't have to go anywhere near the hospital. these have consequences, right? The number one presentation to the hospital, to any hospital in the world, and I challenge any of you to go and Google it, or as I am told now by my Gen Z students, ChatGPT it, is heart failure. Heart failure is a revolving door diagnosis. When I discharge a patient with heart failure, I almost can predict in a few days, weeks, they're going to come back in the emergency room. This takes up resources. Because when that person represents the hospital, the whole algorithm starts all over again, including the investigation. So you're double, triple investigating patients. We can't afford this. The heart failure admissions in the hospital are significant. If you go to the emergency room now, and you just look along any corridor, I would say roughly 1 of the 4 patients that you see in the corridor are heart failure, and the other ones are probably related to acute emergencies. Hospitals internationally have recognized that this is a problem. They have recognized that we cannot manage things the way we did, and so outpatient facilities have had to be redesigned and reformatted. This is what I think this loan might speak to, the expansion of outpatient facilities. But it cannot be expansion and business as usual. It can't be the usual set of surgical outpatients and medical outpatients and, well, I will argue for the expansion of the hypertension clinic, but that's a clear bias. You have to be innovative. Why are people returning? I've mentioned one example, heart failure. Then have an outpatient heart failure clinic. In every other jurisdiction, including many small island developing countries, there is a heart failure clinic. You come in, it is expected that over time you will retain fluid over days or weeks or whatever. You get your shot of Lasix, a drug used to treat heart failure, you go home. You don't come into the emergency room breathless when you're end stage and then have to be admitted. So you delay the admission. We know it's going to happen. We know from the literature it's going to happen. So it makes sense having these units. We are also now moving into a whole completely new era of exciting drugs, biologics. These will change how we treat diseases like rheumatoid arthritis and other immune-mediated diseases. These drugs do not require a patient to be in a hospital bed. They do now at the hospital, but they don't in most other hospitals. Day units, home care, the use of technology like telemedicine and telemonitoring. These drugs can be administered safely in an outpatient setting. So I hope that with the expansion of our hospital, it will not just be an expansion of the existing clinic structures that we have. Let me speak briefly on oncology, because this is something that is going to be a challenge for us for some time in the future. Cancer rates are increasing. They're lifestyle-driven, yes, but there probably is another factor influencing this. As we get older, our risk increases. Certainly we in Barbados can be proud of our decrease in smoking rates, cigarette smoking. I don't know if other rates in other types of smoking are increasing. But certainly we also know that another risk factor that no one likes to talk about is there, and that is alcohol consumption. Even me as a doctor, I don't like to have a conversation with patients about alcohol consumption. But we know there's no safe limit now in medicine for cancer risk, at least in terms of alcohol consumption. This is something that we have to discuss openly and candidly with patients. And so with oncology and the burden of oncology internationally, most hospitals have removed this from the primary hospital space. If you go to St. Thomas's Hospital now in London, you will see this large glass building that you really want to stay there, although you don't want to stay there. It's the cancer center. It's the best part of the hospital landscape. The best views, arguably the best meals, I've tried them. And it's where you want to be treated. Barbados has to move to a new form of cancer care, where we see cancer as a chronic disease and not as a death sentence. with all the sophisticated drugs that are available, we need sophisticated specialists. There was an incident a few weeks ago, or maybe months ago, where the hospital had challenges, I know, with a hematologist. You can't be a tertiary care institution without a hematologist. Hematology is part of internal medicine in some respects, but as I said to a colleague, I am not prepared certainly to manage a hematology patient without a hematologist. These are critical shortages. I've used hematology as an example because I am told that there is now one or maybe two hematologists on staff. That is never enough for a tertiary hospital for a population of this size. I mentioned stroke intentionally. You would say, well, with all these strokes coming to hospital and with a stroke unit, which was driven by data from the George Allen Chronic Disease Research Center on the prevalence of stroke in the Barbados Stroke Study, that they would have multiple neurologists or stroke doctors. There is one neurologist. One neurologist. When that neurologist goes on holiday, or for some reason, God forbid, falls ill, there is no neurologist. Now, I told you about heart attacks and the time that is needed for treatment for a heart attack, maybe 6 hours, give or take, for definitive treatment. For stroke, it's less. And the only person who can make certain clinical decisions for stroke is a neurologist. Does any one of us in here, God forbid, want to have one of us or a relative have a stroke and that neurologist is on holiday somewhere? Because she deserves a holiday, right? The outcomes are completely different. So when we speak about expansion of services and expansion of the hospital, it always sounds good, but we need expansion of specialists and personnel. I also believe that a critical gap in hospital medicine, and I have no experience in primary care medicine except probably as a medical student, the critical gap is the communication between the primary care doctor and the hospitalist. I am guilty of this. There are many times when a patient comes to the emergency room and my very team is seeing them having not even looked at the referral letter from the primary care doctor, because it's almost like a custom. You're the primary care doctor. When they get really sick and they come to us, that connection needs to be made. But that communication is so much easier if you're all using a shared platform, like a health information system that is critical to healthcare delivery. I can almost guarantee you, because it happens every Thursday morning at the hospital, in my clinic, if there are, let's say, 12 patients, a third of those notes are going to be missing. How are you going to manage a patient without their note? You don't have their medical history. The last time I asked someone, you know what medication you're on, so I could at least rewrite a prescription, he said the pink tablets. So these are things that are reality, and I keep thinking, why is it in 2025 we haven't quite gotten there as quickly as we should? So with all of the barriers that I have mentioned, there are, of course, solutions. And what I'm about to say may sound extremely biased, but I do believe, and I don't think that Barbados is the only territory that is experiencing this, healthcare professionals have been decentralized from decision-making in health. And what that has done, it has created a void. Quite often with very good intentions, hospital administrations and other specialists make recommendations. And when they filter down to patient care, the frontline providers say, well, who made this decision? Someone who has no type of medical training or nursing training or paramedical or anything. So it's a challenge. We need to get back in the decision-making space. The very reason that I am standing before you here, Mr. President, is because on many occasions I have said to junior doctors. If you are not part of the solution, then you are part of the QEH problem. If you don't write the complaints, if you don't send the emails, and I know that people at the QEH are probably wondering why they didn't get any emails today, it's because it was here, then you are part of the problem, and you must represent health, and more importantly, you must advocate on behalf of patients, not just on the wards or in the clinics, but in the public space. And so I would close by recommending 3 key things. With this rapid expansion, it should not only be an expansion of the existing structure, it should respond to the health needs of the country, but also be innovative in its design. These data are readily available from our sister countries and even from other more resourceful countries. There should be the urgent implementation of the health information system. This is critical. We cannot continue to manage patients using paper records. It is too dangerous. With some urgency, there needs to be a clear communication portal so that any relative out there watching this can pick up the phone, call an automated system, and be able to speak to the managing team within a certain number of hours, 24 hours or what have you. But it's easy, and we need to prioritize relatives being able to get information. And finally, Mr. President, the hospital is only the tip of the health iceberg. One could argue that the base of this iceberg is primary care, but way below the surface of the ocean is this expanding cause for development of the iceberg, and these are the social determinants of health. We have to address the social determinants of health. If we consider that many of us, and I can give you some data, 4 out of 5 of us in this very space will die of an NCD. That is fact, unless you have some kind of arrangement from a much higher power. We certainly don't want to die from a gunshot or an accident. We will die from an NCD. This is going to be a problem that's going to face us moving forward. We have to come up with creative, innovative solutions. And let me just say, as I said at the WHO meeting in Geneva, for small island developing countries, prevention is not an option. It is the only option, because we cannot afford the cost of treatment if we do not have prevention. We need to invest in prevention and the social determinants of health. I look forward to the expansion of this space, but more importantly, I look forward to the expansion of our innovation in thought in healthcare delivery, how we transform healthcare over the next 5 to 10 years using technology, artificial intelligence, remodeling of healthcare, reuse of people in non-traditional roles, all these things, because our public deserves it. And more importantly, and quite selfishly, I say to myself, I could be a patient at the hospital at any time, and I want the best care for myself as well. Mr. President, I thank you.
Thank you very much, Senator Dr. Connell, for your initial address. What a way to start. Senator, the Honorable Mr. Christopher Baylor.
Thank you, Mr. President. I would like to congratulate my colleague on his maiden speech. He was certainly bold in his speed. Mr. President, it would be remiss of me not to say a few words about Harrison Point. I believe that we must separate the important role that that facility played from the politics of the cost. while I've never seen any accounts for what it costs, and I knew that it cost a lot of money. I have no idea about the management of the funds that were provided, but I can only speak to the lives that saved. And there's an instrument that we use in medicine called the retrospectoscope. We can always find problems looking through the retrospectoscope. But Harrison Point was central to how this government managed the COVID pandemic. I do not believe that if we did not have Harrison Point and all of the help that was provided in terms of materials and manpower from outside of the country, that we could have had the outcomes that we have. Now, this bill, which speaks of borrowing $300 million plus for an annex at the QEH, has been long, long in coming. When we, in 2018, passed the health contribution levy, and it was estimated because of the rate of employment at the time that it would raise approximately $60 million. I jumped so high that I'm sure I hit the ceiling because I heard. Because I thought at the time it was going to be in addition to the voted budget. And that turned out not to be the case. It was, in my words, a transfer of a cost onto the taxpayer. And I listened recently to a conversation where a new minister has spoken about providing parents with bills showing the cost of what services have been provided for the children. It would be wonderful if the same happened in healthcare. In fact, if the government ever wishes to do that, it should be in healthcare, so that we can all see what it really costs. It would probably cut some of the wastage, but persons will realize that it is not really free. It is very, very expensive to treat people. Now, even if all of the $75 million that is currently raised, went to the QEH, plus its normal voted amounts, I do not know if it'll be enough, because healthcare is changing, our population is getting older, our facility is crowded, and we have to really, as Dr. Connell said, rethink how we do things. Are there services that can be delivered effectively and safely with the same or better outcomes in an outpatient setting rather than being in a hospital? Sir, we had a recent experience. Someone, I think it was Senator Walters, asked for a list of the positive things that have been done at the QEH. I am not going to do a juke check Edie shirt, because there have been a few. One can question whether they've been efficient, whether they have come in under budget or at budget, or whether they have gone ridiculously over budget. But there's some landmarks. We had the E&E department that was expansion and renovation that was supposed to cost $11 million and be finished in a certain time, and it went way over schedule and cost $5 million more. Is it better? I will not answer that. But if we learn from our own experiences, that should tell us that if you're going to spend $300 million this time, we better prepare properly. We had better fix the problems before we move in. We have to, at the planning stage, look ahead and see, while we cannot predict how medicine will change and how fast it will change and where it will be in the 5 years at least that will take us to do this, we have to now put in place all the systems that will make it efficient. We can't go in there with paper files. Hospitals digitizing. Do we have the staff, both in terms of clinical medical staff, nursing staff, all the maintenance and experts you need for your linear accelerator, your PET scanner? We have a few years to get it in place. We can't wait to go into a building that is new and put the same people and the same bad practices in. And if you have to import staff, where will they come from? Where will they come from? And all the social and cultural things that could possibly go wrong. So we need to bear in mind that while this 300 million is supposed to be for construction, we have to ask, where will the rest of the money come from for doing all the other things that will be needed? It's fine to build a building and put in the equipment, but there'll be maintenance, there'll be staffing, there'll be drugs, and everything else. So we now have to start thinking about, with this expanded facility, will it earn money? Can it pay in part for its own upkeep? Will it mean that Barbadians will accept it as a place of excellence, and rather than draining foreign exchange to go overseas, will they accept it and use it? So government has a major job to do, unlike the water tanks and all the other things, to educate the public about what we're going to do, and I say we on purpose, what we are going to do, and where will it take us, and what difference it will make. What difference it will make with outcomes for patients. Outcomes for those with the greatest fear, and the fear is fear of death. When you have cancer, that is always a major fear. Mr. President, our hospital, excuse me, continues to have shortages, not only of physical beds, but staff. We recently hired a radiation oncologist who has this unbelievable job of theoretically looking after cancer in a population of almost 300,000 people. One person. That person has to sleep, eat, go on holiday, and do all the other things that human beings do. Have time for prayer and everything else. And we are speaking about expansion. So we are struggling to get a second person. So if you're going to build a $300 million facility, who will staff it? What intermediate grade staff will we have? Who in the Caribbean will be willing to come to Barbados and work for the salaries we get paid and the privileges and benefits that we get? I don't know. So we will have some issues. But we need to go ahead with the matter and provide the physical facility. Mr. President, cancer treatment is expensive. Chemotherapy drugs and all the lot are costly. But I think that there are sources of medications that, while if you look at what happens in the private sector and what happens in the public sector, there are differences in outcomes. So if you're going to speak about a cancer treatment center, there should be a point in time where you can look back, or as Dr. Connell was suggesting, we have to gather the data continuously and look back and say, we have just spent $500 million, and these are the improvements in outcomes. Because if at a certain point in time, you can't see improvements in outcomes, and outcomes don't necessarily mean longevity. It might be outcomes, improve outcomes in terms of your quality of life after treatment. Most people want improve outcomes in terms of longevity. I too want that. We have to be able to look back and see whether, when we have done what we said we want to do, if it has made a difference. But we have to get it right. So there should be provision for lots of research, even on our existing data. But the government has to run it. Government has to drive it. The university can participate at a ground level, and they do, but the government has to have a comprehensive plan. Mr. President, our cancer burden for gastrointestinal cancers and prostate cancer and all the female cancer is large. And every day we hear of someone else in our age group, sir, who has gone the other side. And sometimes you hear the sad stories of delays, and the government, on its positive side, has recently spent a large sum of money. I do not know the exact cost, somewhere in the region of, I think, $12 to $14 million to install a linear accelerator. That has been long overdue. It will hopefully bring better outcomes for those who can be treated. And government has also spent large sums of money in the interim while that delayed project was going on to send people overseas. But we must remember that while we can say we have now started treatment locally, those in the backlog still have to be treated, and you cannot treat them all in one day. So I do not know if the government has contemplated stopping the program of sending persons overseas, but I believe that the two need to run in parallel until you catch up. Otherwise, there will be persons who unfortunately will have poor outcomes because of lack of treatment. You may have a facility here, but because you have a backlog and there are delays, people will still be waiting. Now, sir, I do not know what the start time for the center. When will it be finished? And how long it will take us to correct the deficits that we have and employ all the people that we need to get things running correctly. So I expect that there will be a large committee, not necessarily in terms of numbers of people, but in terms of brain power, who will oversee this major change, because we have a hospital where one department is going to be treated with a $300 million plus injection of capital. And that says that we believe that we have a big problem. the problem that Dr. Connell spoke about with the chronic non-communicable diseases and their complications do not get the same sort of profile as will happen when you build a big, tall new building. But the burdens and the difficulties that we have in the QEH, in the A&E, and on our wards are not going to go away. And they will still probably get worse. Not because the people who are there are not doing a good job, but the sheer volume overwhelms us. So I hope that there is somewhere secretly a plan being hatched to find alternative space to house those people so that the other parts of the hospital that are being stopped from functioning, like the surgical operating rooms because the ICUs are filled, there will be a solution or solutions found to those problems, and that people's outcomes are not made worse because of delays in treatment. So there's no point having an updated ambulance service to get a person to hospital in record time, and then that person waits for 24 hours to have what could have been care that could have reversed their stroke or had a better outcome from an acute myocardial infarction. Sir, the government is definitely looking ahead. I suppose those who are familiar with economics will argue about whether the government can pay its debt in the future or if it's borrowing too much money. My main concern, sir, is that as I prepare to exit medicine, I will not like to look back from that rocking chair and say it really did not change in my time. And every time we spend money and we painfully look back and see that things might be worse, it saddens me and it hurts other people. But sir, what the image that we project about our hospital, sir, is important. And if we project a negative image, particularly if the negative image is projected by the chief administrator, we have a hard time overcoming it. There was a slogan during COVID, no retreat, no surrender. And that was the most positive slogan. But it was equally matched with the one that said, don't come here. And if you tell people don't come here often enough, they will not come. And when they do come, they will always be unhappy. So we now have to work and say, do come here. We can help you. But when they arrive, we must be able to do the things that we say we can do and produce better outcomes. So, sir, I thank you.
Thank you very much, Senator Naylor. Senator Worrell.
Thank you, Mr. President. I rise to make a brief contribution in this debate with regard to the two loans agreements before the Senate. The first being the policy-based loan from the OPEP fund, and the second being the loan from the Sinopharm, China Sinopharm International Corporation, which will go towards the expansion of the Queen Elizabeth Hospital. Mr. President, in making this brief contribution, Mr. President, I wanted to, the policy-based loan, I believe that the leader of government business did not offer us, well, the lead spokesperson did not offer the chamber sufficient information on this loan. And I think when you are discussing a policy-based loan, it is different from the loan from the Sinopharm International Corporation, because we know the specific project which it will be going towards. But I think that the public of Barbados have a right to know where this money, 100 million Barbados dollars in total, will be going to. Policy-based loans are very broad. It's not necessarily to a project. It could be used to pay salaries. It could be used to pay debt. It could be used for a number of things. Even though the legislation said it goes towards social services, our social services in this country are wide. So could we have a specific breakdown of the government intended plan of utilization of this policy-based loan, Mr. President? That, I believe, is information that should be made available to the Chamber and to the people of Barbados. Barbadians are becoming wary of the consistent borrowing of this government, and we are not seeing the residual benefit in terms of the projects that the money is being applied to. Yes, we know that governments need to borrow in terms of continuing their infrastructural program, capital works project, and for economic development. But we have a government that has borrowed money, and many of the projects which they have invested in have not contributed to the economic development or growth of the country. You have a government that has borrowed money, and that money has gone into wastage and monuments, which Barbadians up to this day have no idea what they are for. One classic example, and the correct minister will be responding to this, would be the structure at Newton as you go from Coral Cemetery to the Newton Roundabout. Passed there a few days ago, and the curtain seems to be flapping in the wind, ready to blow off. This is a project which was implemented for Carifesta. We do understand that there may have been a few Carifesta events there, but many Barbadians would like to know, what is it? What is it for? What is it used for? And another critical question, Mr. President, with this government, what was the cost? Because up to this day, we cannot get out of this government an idea of the cost for hosting Carifesta, and further, an idea of the cost of many of the monuments which were established for Carifesta, including that monument at Newton, which is almost like a dilapidated chicken pen at this stage, with the canvas flying all over I believe that to save face, you should rush, Mr. President, the government should rush